All right, welcome back. I hope you're having an awesome time so far. Our next session is titled Using Machine Learning and Natural Language Understanding to Better Understand Patient Populations. It'll be presented by two awesome speakers from Realyze Intelligence. Please join me in welcoming them to our virtual stage.
Thank you so much for having us. We're really excited to share what we're doing here with the conference. I just want to start off by giving a brief introduction of who we are and who Realyze Intelligence. Both myself, I'm Brauser, and my co-founder, Gilan Saadawi, will be doing the presentation today. We have many years experience in doing clinical documentation and natural language understanding and AI technologies within the field. And we have a passion for using both the technology and the clinical expertise, bringing those together to solve real healthcare problems and data problems. We most recently founded last year as a UPMC enterprise portfolio company. So to get going into exactly who we are and what we do, our approach is really to use the latest in AI technology to explain the patient in a way that hasn't been possible up to date by just looking at structured data. So not only do we look at all of the data that's being collected, we look at what's in the clinical charts or the unstructured data. And we take that and combine it with structured data to get a more accurate view of what's going on with the patient. And this really enables a lot of different things. We can prioritize patients that are going to benefit from very specialized care. We can intervene when we see that these patients are heading towards adverse events or high cost events. And then also, ultimately, we can optimize the patient care for it. In the end, our vision is we want to create a solution that can realize the patient and the populations in a much greater detail. The problem that we're really focused on is one that has been plagued for quite some time now. So healthcare has made huge steps forward with digitization, but we're still managing our populations with very broad strokes. So we look at populations as diabetic patients or chronic kidney disease patients, but we really know that patients themselves are very complex. They're not just chronic kidney disease patients. They have many different things going on and they require specialized care. And that specialized care and that complexity is really captured in the description or the patient story that the documents have that the physicians are created. So what we do is we take the structured reports or the population reports and get a large population. And this is what happens today. If you see, you'll get registries and population reports, and you'll get a lot of different categories. Then we put those in today into various processes or different solutions that can take a long time to sort through. So this could be manual care coordination where you're reviewing charts, trying to find those specific populations. And the challenge here is that there's so much volume to be able to automate this or actually do it at scale. It's very difficult. And what ends up happening at the end, we get both under and over treatment of this population by when we're trying to figure out which ones need various care, whether it's a specialty, whether you need targeted care coordination, or even some very high-end or expensive treatments. So what we do at Realyze is we start with that same type of population. In this example, I'll use a chronic kidney disease population. So if you have 100,000 chronic kidney disease patients, what we do is we take those patients and then we review all of their clinical charts, so the narrative description of what's going on. And then based on that, we use natural language processing and machine learning to interpret what all of those complexities are in there. And then we create what we call live registries or patient prioritization. And that allows us then to map very specific categories to specific resources that are needed. So in this case, we can take all our patients that the documentation clearly shows that they're stage 3B or 4 that aren't yet on dialysis. Let's get them to a specialist so that we can prevent them progressing further. If a patient is already at end-stage renal disease, maybe they need a different health plan or a different care plan in order to manage that very high-risk patient population. And then there's cases where you might be looking for which candidates need dialysis or which candidates could actually benefit from a transplant. We want to find those categorizations of which patients are not yet on dialysis but are clearly progressing. And again, the way that we do this is we look at all of that information and descriptions that are in the notes that the doctors are clearly documenting and having conversation with the patients, we categorize that so then it can be used in an actionable way, in a timely way. So to give an example, specifically on what types of things, we all know today with the EMR and structured data, we can get claims data, we can get the problem list. The challenge with some of this information is it might not be up to date, or it might not be maintained correctly. We all know the challenges with keeping the problem list up to date and all the changes there. But we can get labs and vitals and drop down. The way that we see that, that's a good start. But then we take that and then we add to it all of that richness that we get out of clinical notes. The current conditions, the comorbidities, the procedures, even things that might be negative or things that have been ruled out. That will give that level of information. And then there's more even expansive things like social determinants of health. Does the patient live alone? Are there food insecurities? This is all rich information that can put those patients into certain categories. And again, going back to our CKD example, when we look at the structured data, we can do a pretty good job of finding our broad population by looking at which ones have claims for chronic kidney disease or have problem lists that are there. But staging becomes a challenge. We might use the GFR lab result, but that might be caused by some other condition, or it might be a case where they have acute kidney injury that gave it a spike and then it's not chronic at that point. So there's a lot of false positives. So what we do is we start with that, and then again, we can now go in much deeper. We can look at what the actual clinician documented as the stage and the current stage, the most recent stage. We can look about what other things are in the notes. There might have been a conversation about dialysis. There might have been conversation about various treatments. And then of course, all the other conditions and things that could be impacting. So that's what allows us to do that. Now I'm going to turn it over to Gilan to go into a little bit more detail about exactly how our technology and clinical expertise comes together.
So thank you, Aaron. This is a very simple high-level description of our platform. As Aaron said, we accept both structured and unstructured data coming from EMRs, EDWs. All patient notes passes through a process of HL7 integration. Through our pre-processing pipeline, we actually do data normalization of these patient notes. We use basic natural language processing to map these concepts into LOINC, RxNorm, and SNOMAD. Then we add our artificial intelligence and clinical expertise as an extra step so that we can model these concepts into a patient state. So, for example, you start by modeling a chronic kidney disease patient, then you keep adding all the findings and model another disease condition, COPD, social factors, if the patient has been exposed to COVID or even cancer and oncology. By adding all of those and creating these models, we create FHIR-compatible models that are at a concept level, at a patient level. These models can either go into our Realyze web-based applications, where we give you the prioritized list and detailed information of the patient, or if you have an existing EDW or an EMR, and you just need to enrich the data in that EDW or EMR, we pass it as FHIR models, or eventually in the EMR workflow when appropriate. Okay. Again, to simplify the process, and this is a very simple way of representing things, the documents will pass after it's being normalized into an HL7 stage 3 and then pass through our NLP. The mapping happens to the ontologies. We use the SNOMAD as our main ontology, but we use RxNorm and LOINC for medications in lab. Once the concepts are being identified, we remove the noise and then we create a model. So in this simple example of a diabetic ketoacidosis patient, you will never find that concept is already there. So it's more than simple mapping to an ontology. It's actually creating a model that understands that a ketotic smell in an obese patient that's on insulin with a high level of glucose at admission probably is a DKA patient. That is simple for the clinical and person, but it's very sophisticated for the machine learning. And that's what we do, is add that level of clinical expertise into the model so that we can understand what a clinician will understand in the end.
Yeah, and as you can see, we have great technology and great clinical rules, but the end of the the solution that we focus on is what outcomes can we drive? And here's some examples, some other outcomes of not just doing the technology for technology's sake, but we can find CKD patients progressing to dialysis, but also things like which patients would benefit the most from COVID outreach, or which patients would need other disease that might cause high prevalent events. And this is a long tail of things it can do. And as Gilan said, the more we use the models, the more expansive we can end. So thank you again for joining us today. We're really excited about the capabilities here. And for more information, feel free to reach out to us here at Realyze Intelligence.
Awesome. Thank you so much. Thank you both for sharing with us. If you could just stop sharing your screen, I know the audience wants to give you a huge virtual round of applause. Thank you. We appreciate their time today. For the audience, it's time for you to make your way to your next session. Along the way, make sure you accept those connection requests and check out our amazing AI exhibits. Thanks so much, and we'll see you around.